Welcome everyone to this edition of the ACTnet Journal Club. I'm speaking to you from Wurundjeri land, and I acknowledge elders past and present. I'm very excited today to have Dr. Emily MacLean present. Emily is a colleague who I'm trying hard to work with and collaborate with. From the University of Sydney. Yeah, we will. We'll get there. And Emily's already at her very tender career, already very distinguished. She's contributed to multiple WHO policy documents on TB diagnostics, and is part of the core writing group for the target product profiles to test for TB treatment optimization. She's an epidemiologist by training, and she has lots of skills which I hope to leverage in methodology and implementation of new TB tests, particularly for vulnerable and as yet under-researched groups. She's leading a landscaping systematic review of TB biomarkers, so I'm very excited to hear her expertise on the current trial that she's presenting, which includes assessing the use of tongue swabs for TB detection in the under-researched population of adolescents, and also developing a predictive model for TB in household contacts in people with multi-drug resistant TB. She works closely within the TB-CRE as an associate investigator. Is that right, Emily?
Associate investigator.
Yeah, and is one of Greg Fox's proteges. So, without too much more of ado, I will hand over to Emily.
Thanks, Gail. Hi, everyone online. Thanks for having me present today's journal club. I'm just going to go full screen. Let's see if it works. Okay, that seems fine. Great. So before beginning my talk, I'd like to recognize and acknowledge that here in Sydney, I'm meeting on the traditional lands of the Gadigal people of the Eora Nation, and I'd like to pay my respects to elders past, present, and emerging. So the paper that I will be talking about today was published in Clinical Infectious Diseases earlier this year. It's called Enhanced Tuberculosis Diagnosis with Computer-Aided Chest X-ray and Urine Lipoarabinomannan in Adults with HIV Admitted to Hospital, the CASTLE study, a cluster randomized trial. And this study was funded by the Wellcome Trust, and as stated in the paper, at least the funders didn't have any role in designing or reporting or conduct of the study. I don't know how sorry, this is my first ACTnet journal club, but I guess I would just say that this group who authored the study, I don't know how much we comment on the research teams in the papers, but they've been working in Malawi for a really long time. Peter McPherson and Elizabeth Corbett are very distinguished TB researchers. And they've been working on HIV TB for, I want to say, a couple of decades. I actually had the opportunity to talk with Rachel Burke, who's the lead author on this, when she was a PhD student. And I guess maybe just some context that we'll get into is because this team has been working on TB and HIV at this particular hospital for so long, they've actually really seen a decrease over time in TB prevalence. And a lot of that, they think, can be attributed to the work that the research team and I guess participants have accomplished over the last couple of decades. So I thought that that's maybe some interesting background information about how, situating the study. So not needing too much background because of the audience, but TB as the leading global infectious disease killer also happens to be the leading killer of people living with HIV. And it's the leading cause of hospitalization of people living with HIV, which I learned from reading this paper and did not know previously. diagnoses of TB are frequently missed, particularly in this population. And I think that's largely to do with difficulties with the existing tests and testing strategies for many people who actually need a test. So in the case of people living with HIV, many of those folks can't easily produce a sputum sample. So the tests that we have and that are endorsed by WHO largely are sputum-based tests. And so you have a whole group of people who are at very high risk of disease who can't get diagnosed. And the result is very high mortality rate of TB in this subgroup. But fortunately, we do know that there are some TB tests that are available that have demonstrated that they are life-saving. So in particular, the Urine test, previously manufactured by Alere, now purchased by Abbott. But the Determined TB test has been shown, I think in 2 trials, to be life-saving among hospitalized, severely ill people living with HIV. And that's because you're able to get a urine sample from anyone, and that positive signal gives you the confidence to start treatment immediately. And that's kind of the mechanism by which people think it's a life-saving test, because it allows you to start treatment right away. But this finding has not been extended or shown in all populations. So there's still some question of, can we use lamb-based or urine-based testing strategies to kind of help get at that persistently high mortality. So kind of in my words, I would sum up the research question of this trial as, is it possible to develop testing algorithms that incorporate novel diagnostics, or in study parlance, enhanced diagnostics, to start people living with HIV on TB treatment? And by doing so, can we reduce mortality? So that's not stated in the paper, but that's my interpretation of what the authors were actually trying to get after in the study. And in the authors' words, their objective here was to conduct a randomized trial to determine the effectiveness of enhanced TB diagnostics plus usual care on TB treatment initiation compared to usual clinician-directed testing among adult people living with HIV admitted to the hospital. I thought that maybe this would be a good opportunity to talk about why I picked this study and why I thought it was interesting, and maybe if you're interested in testing and TB diagnostics policy, this will be interesting for you as well. But I've been involved recently with developing some guidelines with WHO TB program on evidence generation for new TB tests. And basically, there's kind of 2 forms of evidence that we think about when we're considering new diagnostics. So we can think of indirect evidence and direct evidence with respect to how well a test does its job and how well it's able to kind of affect patient level outcomes. So the first kind of evidence that is much more common in the literature when we think about how well a test is working is indirect evidence. And this typically is evidence that comes from diagnostic accuracy studies. So taking a new test or an index test or an index test strategy and comparing it to some kind of standard, reference standard, and getting diagnostic accuracy measurements. So you combine this kind of sensitivity and specificity, or area under the ROC curve, with some assumptions, and you can assess what you expect the effects of a new test or testing strategy would be on the final outcomes. So you're kind of extrapolating test accuracy to a final outcome like treatment initiation. I think, for example, if my new test has high accuracy, it's going to lead to a lot of people starting treatment. So in this sense, this kind of design would provide indirect evidence to policymakers that the effect of using a test on a final outcome is captured by linking together multiple different pieces of evidence. So that's most diagnostic accuracy studies. And when the policymakers are sitting together thinking about, okay, do we want to recommend test A or test B or test C? Most of the evidence they have to deal with and make the decisions is this kind of indirect approach. But this study at hand, the Burke-Castle trial, is actually, I think, a good example of taking a direct approach to understand whether your test works well or not. So in studies that are taking this kind of approach, the final outcome of participants is compared directly between the people who receive the index test or the new strategy compared to a standard or a comparator strategy. And then you actually go forward in time and manage the study participants based on the test results. So that kind of gives you a more direct measure of whether using a test is going to impact health outcomes. And this kind of evidence is a lot rarer and I think a lot more expensive to generate, which probably explains why it's rare. But I thought that this study was a good example of diagnostics research taking the direct approach to see how well the test works. And that was why I picked to talk about this study. Anyways, that's a bit of an aside. But getting into the design of the study. So this was a cluster randomized trial, not control, but control being standard of care, I guess. Recruiting from late 2020 to early 2022. So as you can imagine, they had some COVID-related disruptions, but they persisted in their recruitment. The clusters were 24-hour periods, and those were chosen pragmatically, basically. So all eligible participants on a morning post-admission ward round would receive the intervention. So basically, they picked a cluster that would reduce contamination, and so that everybody who was getting admitted on the same day could easily be given the right intervention. The cluster allocation was concealed, but then once the arm of the day was chosen, everybody on site, including participants, was aware of the intervention. And they used a 4-4-1 randomization scheme. So diagram here, we have our source population who were then randomized to receive usual care in the ratio of 4, enhanced diagnostics plus usual care, also ratio 4, or the diagnostics cohort in the ratio of 1. And we're not really concerning ourselves with this group today, so that's why it's kind of whited out. The study was done at the Zomba Central Hospital in Malawi, which is a tertiary referral hospital and the main referral center for southern and central Malawi, and I guess surrounding countries as well. Sometimes participants could be recruited from there. But they see inpatients and outpatients. There was really a lot of TB there, but as I discussed at the beginning, that prevalence has really decreased in the last decade. But there still is a very high burden of HIV. In Malawi, there's approximately 1 billion people living with HIV still. So study population was, there's a lag between my computer and the screen, apologies. So adults who were aged 18 years or older and diagnosed with HIV and admitted to the hospital less than 18 hours before the trial would have tried to recruit them. So people who have recently shown up to the hospital. People had to consent or be able to consent. And there were no symptoms-related criteria for recruitment. So you could be symptomatic or you could be completely fine, but as long as you met the other criteria, you were invited to participate. And as is standard in studies evaluating TB tests and testing strategies, participants were not eligible if they were currently taking TB treatment or if they had taken TB treatment within the past 6 months. And that's just because if you had taken TB treatment, then your TB may present differently. And because of the effect of the treatment on the bugs, you may kind of get a false negative, and also you're not really the same as the rest of the group who are enrolled. So nobody currently or recently taking treatment was eligible. So on to the interventions. So the first arm was usual care, which I've colored in pink throughout the presentation just for ease. Basically, in this arm, people were allowed to receive any TB tests that were usually available. The paper says usually. I don't know what the difference is between that and always, and maybe some of them aren't always available. But what would typically be available is what people in this arm would have received. So chest x-ray read by a human, whether that was a radiologist or GP trained to read chest x-rays. The determined TB LAM test, so the WHO endorsed urine LAM test. And if they could produce sputum and the doctor wanted to order a sputum microbiological test, Expert Ultra was also available. So all of these were up to order any of these tests was up to the discretion of the attending doctor. There was no protocol mandated testing. And so this arm was really set up to try to mimic what normal care would be like on a regular day in their setting. In the other arm, we had the enhanced diagnostics plus usual care. So this is really the intervention in the study. So you had usual care options, and you also had study tests. So instead of using a conventional chest x-ray, there was a digital chest x-ray, and instead of it being read by a human, it was read by an AI-based imaging processing software called CAD4TB version 6. CAD4TB, I think, has received recognition and endorsement by World Health Organization. So this is a commercially available software that has read many, many, many chest x-rays in the past. We had the determined TB LAM test, so the already approved test, and also a new generation urine LAM test made by Fujifilm, which we'll call FujiLAM for short. So FujiLAM, like the determined LAM, is a lateral flow based urine test, but they've added an extra, I think there's an extra antibody that has a signal attached to it that amplifies the LAM, so it's easier for the eye to pick up a human eye to pick up a positive signal, and the antibodies theoretically can bind the LAM better and at a lower concentration. That's the claim, anyways. And then you have molecular expert ultra again. So I just wanted to make a note here about the CAD4TB. So the readout for the CAD4TB is basically a score going from 0 to 100. 0 being interpreted as extremely unlikely to be TB, and 100 being extremely likely that this is TB. So the probability of TB increases as the CAD score increases. And it's up to the people using the software to determine what their cutoff is going to be for the software to make a positive call. And they explain in the paper that they chose a cutoff of 60 based on reviewing the chest x-rays that they've seen in their setting and expert opinion, basically, kind of tailored to what they expect to see and what they've historically seen in their setting. There were also a couple other procedures worth noting. At the time of recruitment, all participants attempted to provide a sputum for culture, and this was to be used later so that they could quantify whether there were any TB cases that were missed at baseline that neither of the strategies captured, which I thought that was kind of a clever way of trying to do this. Also should note that people who could produce sputum in either arm could also have the expert ultra test ordered. And the decision to initiate TB treatment was made by routine clinical staff. So the people who are most familiar with the setting and are working there every day were the ones who were making the final call. interpreting all the test results, including the study test results. Lastly, in the methods, we have a couple statistical issues to walk through. Sorry about the lag. So for the sample size, this was a cluster randomized trial. So there was 102 clusters. And basically, this means that there was 102 days to be randomized. The inter-cluster correlation was 0.005, which I understand to be very low. They expected to see 3 participants a day, and approximately 10% in the usual care arm would have initiated TB treatment. So that's how they got to their estimate of 102. This would have given them an 80% power to detect an 8% absolute difference in treatment initiation between arms, or a relative risk of about 1.8. So one thing I thought was interesting, but I don't have the statistical expertise to really comment on, is they analyzed their data at the individual level, although things were clustered on the day level. I was trying to think, is this kind of reasonable? And kind of my best guess is that I suppose the ICC is very low here. And if they're cluster randomizing every day, I don't think that there's a reason we would expect there to be systematic differences between people coming in on various days. And if there were, the randomization should break any link between those systematic differences. And so people should be evenly sorted between arms. So I think that this is probably the appropriate analysis, but because this was CID, they don't really get into the nitty-gritty of the statistics at all. So maybe that's something we can discuss. If anyone has any different opinions, I'd be very curious to hear what you think. With respect to the outcomes, our primary outcome was TB treatment initiation before hospital discharge or death. To estimate this risk ratio between arms, they used a log binomial model, and there was 2 pre-specified subgroup analysis. So the risk of TB treatment initiation amongst people who had TB in their baseline differential diagnosis, and among people whose CD4 counts were less than 100 cells per millimeter. Secondary analyses, death at 56 days. To estimate this, they used a Cox proportional hazards model. TB treatment initiation within 24 hours, estimated using a log binomial model, and missed baseline TB, which in the end was a very rare event, so they used Fisher exact test to test between arms. So now moving into the results. So there were 302 clusters that were randomized. There's the 4-4-1 ratio of clusters randomized to usual care, cluster randomized to enhanced TB diagnostics, or the diagnostic cohort, which will be a separate paper. I imagine that they have other tests that they added on for this diagnostic cohort, and that they did more intense reference standard testing. And maybe they had wanted to do that for everyone, but maybe there wasn't enough money left over in the end, and so that was the choice here. That would be my guess. There were a number of people excluded, but the vast majority of these exclusions were because people were HIV negative, so they didn't meet their eligibility criteria, or they didn't consent to the study. And so we have our clusters: 106 in usual care, 102 enhanced care. And a few people withdrawing, although I think a pretty negligible number. Apparently everybody was in the study for assessment of the primary outcome, which is commendable. And almost everybody was still in the study at 56 days for assessment of all of these secondary outcomes. So very high rate of follow-up in the study. Oh. Those colors were supposed to be there at the beginning, sorry. Okay, so table 1. Here we have the usual care in the left and enhanced TB diagnostics arm on the right. So we can see on median, I guess not on average, there are 2 people a day in each cluster. Seemingly very well balanced between the arms. Maybe a little bit more women in the usual care arm compared to the enhanced TB diagnostics arm, but nothing serious that I would feel too concerned about. People mostly on ART, some cough, some fever, some night sweats. So the majority of people have more than one TB symptom. Differential TB diagnosis at admission, around 30% in both arms. I think this is a pretty sick population. I mean, half of them aren't able to walk without assistance, which is a bit sad to think about, that people have waited that long to get to this healthcare center. But I suppose it is a referral center, so it's really going to be the sickest people who are making it here. And CD4 count a little bit higher in the usual care arm, although the distributions are quite overlapping. So looking at the effect of the intervention. So in the pink, we have the usual care again. In the blue, the enhanced TB diagnostics. So our primary outcome of TB treatment initiation during admission. In the usual care, 24 people started TB treatment versus in the enhanced TB diagnostics arm, 46 people initiated treatment for a relative risk of 1.92 with a confidence interval that does not include the null and an absolute risk difference of over 10% higher. So people are starting treatment more in the enhanced TB diagnostics arm. And in a second, we'll talk about what is really driving that. Secondary outcomes, TB treatment initiation by subgroups. We can see that in the enhanced, when we break it down, in the enhanced group, enhanced test group, more people are starting treatment if TB was in their differential diagnosis at admission. And also among people where that differential diagnosis was not actually inclusive of TB. It's also true when you more people are starting TB treatment in the enhanced diagnostics arm when you stratify by C4 counts. But then if you look at the secondary outcomes in this gray at the bottom of the table, undiagnosed TB at discharge, not estimated because it was such a rare event. There's no events in one of the arms. TB treatment within 24 hours of admission. There's no statistically significant difference here, although I suppose a trend towards the enhanced TB diagnostics arm, but certainly large confidence interval that covers the null. And in terms of death at 8 weeks, there's really no difference at all. Hazard ratio of 1.05, and really, quite symmetrical on both sides of the null. So just to look into that impact on death, here's the, flip survival curve with the percentage of participants who died on the y-axis and the time from enrollment on the x-axis. And you can see that those two curves, the red being usual care, the blue being enhanced testing, really are crossing over throughout the full follow-up period, such that there's no difference really at any point in mortality between the two arms. To look at what's driving the case notifications. So we did see that more people were starting TB treatment in the enhanced diagnostics arm than in the usual care arm. And the authors conclude, and I think what we can really see from looking at these test results, positive test results, is that the in the enhanced arm, the thing that's driving case notifications is more positive results on running the determined TB-LAM test. So each bubble is a different test. And remember, in the enhanced TB diagnostics arm, people were obliged to run the urine gland tests and the CAD tests. And we can really see that obliging people to test with urine lamb more is, when we look more, we find more TB. And that would give people, I guess, the confidence to start TB treatment for someone who has that positive result. Interestingly, although the Fuji lamb, the Sylvamp lamb, should be detecting the same part of the cell wall that Lipoarabinomannan lipoglypid, it doesn't actually seem to have super good concordance with the determined lamb. Interestingly, it does have 3 of its own positive results that weren't detected on any other test, but it only picked up 3 of the over 20 positive results that the already approved urine lamb test did. So definitely some questions about the test's technical analytical performance. When this study was being analyzed and written up, there was a pretty definitive study published that showed that the Fuji lamb had really severe lot-to-lot variation. So I think due to manufacturing conditions. And I think in the discussion, they go into this pretty thoroughly and suspect that the batch of tests that they got was maybe in one of these lots that actually was shown to not work super well by this other completely independent validation study. So for me, I had a couple of outstanding questions. I think I talked for about half an hour, so this is a good time to get close to the end. I was interested in their application of the exposure of the CAD for TB. I was interested in why they used a cutoff of 60 and why they wouldn't use something from a systematic review meta-analysis done in their part of the world. Because there definitely, I'm not a TB HIV expert by any means, but I think there has been a lot of work done investigating the different CAD softwares in and around all parts of Africa. So it was interesting to me that they made their own cutoff, which was maybe a bit higher than I would have expected. I was also curious what happens if the CAD score is less than 60, but the patient is sputum producing. Does that kind of give you any sort of bias, like kind of falsely reassuring, like, oh, maybe we don't need to get a sputum from them because the CAD score is higher? This is a figure from the supplement showing the distribution of scores and the number of participants who are in each bracket. Quite a few people who were CAD, I guess, positive over 60 who didn't start TB treatment, but then also people under 60 who were treated for TB. So the authors conclude that CAD is a nice adjunct test, but certainly is not the be-all, end-all. The non-agreement between the Fuji lamb test and the determined lamb test was certainly troubling and discouraging to see. I think that a urine-based test would be really helpful for a lot of people who need TB tests. So it's a bit depressing to see that actually the version that we have right now is really seemingly not working well at all. And then the last question I was kind of pondering was, why was there no kind of more lasting effect and more downstream effect? We saw more people starting TB treatment, and why doesn't that seem to extend to even 8 weeks out? And I think this speaks to a kind of larger and difficult question of how we can measure the kind of larger impact of TB diagnostics and why we really need direct evidence as opposed to indirect diagnostic evidence. There's quite a bit written about this in the mid to late 2010s. Basically, the people who thought about this postulate that just in the case of tests, because a test on its own doesn't really do anything, you have to have the test results and then act on them. The contextual factors of your study or of the place where you're trying to implement the test are really important and can actually really drive what you see in a way that maybe you wouldn't observe in a treatment trial. In particular, trial conditions for diagnostic trials are really unique. Like in any, although I guess there are some shared features across diagnostics versus treatment trials. Complex cases may be excluded. People in kind of like the gray zone are often not actually included, even though we'd want to know how the tests work for them. There's very high rates of study retention, higher adherence to protocols and treatment if that's part of the intervention. And in diagnostic studies, we often see an increase in empirical treatment, even if the person isn't in the intervention arm. Because they're part of a study, the study team may be more kind of primed to think about the particular disease at hand and start treating empirically if their index of suspicion is raised kind of a lower amount than maybe it normally would be. So these factors can lead to an overall reduction in mortality, even without doing anything different. It's just the context of the trial that you're operating in. And another thing that may drive a lack of difference in mortality could be that the standard of care in a trial is actually better than what you would see in real life settings. So this is kind of in general leading to an overall reduced probability of seeing your outcomes, including death. And so then when you go to measure them, you actually end up being underpowered. And you may have been underpowered a little bit to begin with because trials are very expensive to do. So there's all these kind of non-test related factors that may be impacting and kind of biasing your results away from seeing an effect, even if it was there, just because you're measuring it in this kind of artificial environment. And if anybody is interested in reading further about this, this systematic review by Samuel Schumacher from 2016 has kind of he really gets into the weeds of like, this is the chain of events from test to outcome and all the things that can happen in the middle, and why we may see an impact on patient-borne outcomes or why we may not see them. So I think this is very interesting. If you're not interested in diagnostics, it's probably not that interesting, but for further reading, in case you are. So that's really all the slides I had prepared. And thanks so much for your attention.
Thank you. Thanks so much, Emily. That was a super clear presentation. And I haven't read the paper, so it was fantastic to have it synthesized so succinctly and clearly. And I also, I wasn't aware of the concept of indirect versus direct approaches to outcomes of diagnostic tests. And just to ensure, I'll open the floor. Please turn your mics on and ask questions, or you can pop them into the chat. But I'll begin by asking, I guess, just so that I make sure I understand, is the direct approach, Emily, was sort of you have a test and the outcomes, as in the Schumacher paper, would be that you're looking at what we typically use as, outcome metrics in a TB treatment trial. Like, were they cured? Did they have sputum culture conversion? Did their ECOG score improve? Did they have less symptoms? So sort of a material outcome that's potentially important to the patient. Whereas the indirect approach would be that you have a test, and the indirect efficacy of that test is the patient started on treatment, but that doesn't necessarily mean that they had the disease or that they get better from it. Is that right?
Yeah, I would even go further, and say that indirect approach is really not even including an outcome like TB treatment initiation, but really an outcome that's specifically test-based. So sensitivity or specificity, time to test result availability, and then making that kind of cognitive leap from, okay, this test, we had the results back in 1 hour. So that means this test is going to increase retention in care because the results come back quickly. Whereas if you directly tested that, you would say, okay, what proportion of participants are staying in the study when I use this 1-hour test versus, the regular 24-hour turnaround. And that would be a more direct way to evaluate that. But it's hard and it's expensive to evaluate those kind of questions, seemingly, which I think is why it happens a lot less than extrapolating accuracy and time and user friendliness and what have you to impact and uptake. But I think there is a growing interest from the policymakers to see more kind of direct evidence when they're recommending new tests, since I think especially for TB, what WHO says has a lot of weight for TB programs in high TB burden countries, and they don't always have that much money. So they want to make sure that the recommendation they're making will actually be impactful for people who are getting tested. So I think that's kind of driving this growing interest in generating direct evidence versus just accuracy, indirect evidence.
We don't have, does anyone have any questions? If you do, please raise your hand. Go ahead, Harry.
Hi, Emily. And sorry I was late. Daylight savings time on the east coast of Australia causes chaos.
It's chaotic.
Yeah. Do you think the tests really worked? Because it seems so concerning that the 3 lamb assays that were applied, it just seems so discordant and discrepant. Is that all that's driving? Like, was a whole bunch of these people diagnosed with TB when they didn't have it, and that's why there's no difference in a patient-centered outcome, or conversely? It just seems like the diagnostic accuracy of the tests was the problem.
Yeah, I think that is a really good question. I think the Cochrane reviews of the determined TB lamb test, so the one that's recommended by WHO and some countries that have high burden of HIV and TB together, do actually use programmatically. I think the Cochrane reviews show that the specificity is kind of low to mid 90s. So it's when you compare to microbiological reference standard. So I'm sure some of those false positives are actually missed cases of TB, but I think it's also very possible that some of those are genuine, false positives, and a positive result on a urine lamb test alone may lead to someone being falsely diagnosed with TB and overtreated. And that totally, I think, could contribute to a lack of outcomes kind of even 8 weeks down the track. Because it's like, oh, did you treat these people with TB and prevent death, or did you just treat some people and then that didn't do anything?
Yeah, completely.
I'm not sure if they prevented much.
These are like undernourished people in Africa with low CD4 counts and HIV. You'd think that if you were really discovering more TB and treating it, you would hope that you'd see a patient-centered outcome improve.
Yeah, it's interesting when you look at the literature around GeneXpert, for example. Like, we know that GeneXpert increases the rate of TB that we find in populations that we use it in. But the evidence is really kind of, when you look at the systematic reviews, it's really on either side of the null as to whether, or maybe I guess it's null and it shows some effect, but it also shows null result. I don't think there's much work showing in the other direction. But it's either seems like in some settings, yes, using a molecular rapid test that's highly sensitive is going to lead to reduced mortality. But sometimes, and many studies have shown actually a zero outcome effect. And so I think that working in the testing space and thinking about these further downstream outcomes, they really are really far away from the ultimate kind of decision maker, which I think would be if you administer treatment or not. Because there's so many things between starting the study and getting the test, and then starting the treatment, and then taking enough treatment and to prevent you from dying, and then having the risk of dying, and then passing it. So I think you would need to have really large studies to actually be able to see it, and I think that that's maybe just not happening. Like, I wonder what an IPD meta-analysis would look like if you could really break down mortality based on tested status or not. Yeah, I would imagine there will be a cost effectiveness accompanying study to this to look at, okay, if we use this enhanced diagnostics in our algorithm, how much is that costing per new case detected and per dolly averted?
Emily, we have a question from Mona, who has asked whether you think the test, I guess the enhanced scare diagnostic algorithm that we applied was going to work. It's a similar vulnerable population where TB is treat, pediatrics who have paucibacillary disease, same as people living with HIV.
So my understanding is that the accuracy of the determined LAM test, so the currently approved one, in children is fairly good. I mean, even in adults with low CD4 counts, the sensitivity isn't great, but it's moderate, and I think it's moderate as well in children. For the Fuji-LAM test, there's definitely less evidence, but I think it was looking fairly promising as well, at least until all these manufacturing problems started, with the lot-to-lot variability and leading to how well the test can pick up the signals. But I think because a lot of the time pediatric TB cases or children with TB would have some form of disseminated TB, and I think the urine LAM is a good target for disseminated TB. Whether the CAD for TB will work in the pediatric population is a question currently being investigated. The CAD softwares aren't recommended by WHO for people under 10 yet, and I think that's just because it's hard to get the chest x-rays and to characterize the participants well enough that you can make a definitive call, and then you want to train the software on these images, and there's just not enough data to train the models, basically. So whether or not they'll work as well, digital chest x-ray plus CAD will work as well for pediatric TB, I think is still very much up in the air. I would imagine that unless the developers have really a big stack of images that they can make kind of a child-specific model, that they probably won't work as well, unfortunately.
I think that one of my main concerns with this was the fact that the participants who enrolled into this trial were by clinicians' discretion about whether they could have TB or not. So is that correct? So there was a whole pool of people who were admitted to the hospital who, could have had TB or could have had HIV, could have had both, that never went into this algorithm of testing. And couple that with the fact that we don't have a gold standard for how we diagnose tuberculosis in which is paucibacillary or hard to detect in people living with HIV. It's difficult to know, as Harry and the data is really showing, is what's real, what's the real test, who actually has tuberculosis. Or what are we comparing this to know what the truth is? That for me is really tricky to understand. I was also a bit disheartened to see that there was a mortality rate 50% in both groups. So that's extraordinarily high for
mortality. 50.
Maybe I understood that, but
death at 56 days was about 25% in each group. So 1 in 4, very high.
Still extraordinarily high,
very high
at the 56-day mark. And from my understanding, usually we see that 20% mortality in PL-HIV who have TB when you have a CD4 T cell count of less than 50. And that's certainly not the median CD4 T cell count.
No.
So I guess this is, I wondered, and the ECOG status of these patients, the fact that they couldn't walk meant that they were unwell. Even if they had a decent enough sort of CD4 T cell count at 200, meaning that weren't that immunocompromised, there's still something about this population, perhaps the fact that led them to a tertiary hospital setting in Malawi, referral center, that meant that they weren't. They were a really vulnerable group for whatever reason, and I don't understand the setting. I've never worked in Malawi, so I don't know.
Nor have I. This is definitely a subpopulation that I am not very familiar with. But I totally agree with what you were saying at first about how do you discern what's real and what's not real. And I'm not a clinician, so I don't know how clinical people make decisions, but I imagine a lot of it is just based on your experience that you gain over time. And it could be interesting to see, like, what does a really experienced clinician who works in this hospital, like, how well is their decision to treat kind of aligning with these test results?
Do you think, Emily, that's what we're seeing, though? Even though, I mean, I'm struggling to understand the CAD for TB findings as well. Okay, so in people living with HIV, all those chest X-ray changes that you see, and certainly the CAD models, at least my understanding, they haven't been trained on PL-HIV populations, is because they have so much lung pathology. They might have, PJP infections. They have other pathogens. They might have other disease processes. So it's hard to sort of work out what is tuberculosis versus other pathologies that you'd associate with someone who has a new diagnosis of HIV. But I was sort of, this is exactly as you say, in this population where we don't have the perfect tests to understand whether they do or don't have TB, you end up, it does come down to the physician gestalt of the guesswork of, yes, I think they do, and I'm going to start them and commit them often to TB treatment. And I think that's why we're seeing those GAD scores where you sort of, regardless of the score, did get TB treatment.
No, I think that there's some kind of statistical analyses that you could try to get around this a little bit. You could do a Bayesian latent class analysis to estimate test accuracy, and then based on your updated test performance, I suppose you could make a rule like, based on this LCA derived accuracy, I trust this result X amount, and so I would feel comfortable giving treatment if it passes this threshold. Like, that could be one way to do it, but is that really any better than any other approach? Like, I don't know, it's certainly analytically complex to make those models and to tailor it to the setting and the variables that are at hand. So and again, that would only give you really accuracy, which is like indirect. And if we want to say, does this test have a lasting impact on patients, then those models aren't going to tell us that we just have to take those findings and then apply them. So then even if you kind of try to get around it statistically, you're kind of a step removed from seeing directly how well they're working to achieve particular ends. So anyways, I think it's really interesting. Hopefully everyone thought this was an interesting paper. I realize we're almost at the hour.
Thanks so much, Emily. I mean, and to Gail's point about what do we know what real is, when you don't have a gold standard that you think is extremely sensitive, then in many ways doing the direct outcomes trial like this one is the way to get around that problem, isn't it? But I mean, this is extraordinary effort in how many clusters? Like it's hundreds.
Yeah, like over
hundreds of clusters, and still didn't end up with that many patients, and difficult.
perspective, is this paper then saying in order to achieve, what was it, was it a hazards ratio or risk ratio of 1.9, so that increment in your diagnosis of TB and PL-HIV, you'd need to apply CAD plus several different labs, because there was no consensus in terms of this testing. The logistics of doing that feasibly in a high burden, low income setting, it's not feasible, is it? I mean, we're not going to go through that effort to do that.
And even if this is kind of a bit of a tangent, but I worked on a survey at one point, and we asked countries that had they were designated as high HIV TB burden countries by WHO, and we surveyed the NTPs to ask, like, are you using the determined LAM test, and if no, why not? Many of the countries were, but many of the countries didn't have it in their policies and weren't using it, and kind of the top barrier was cost. But the test was about $4 US, so the cheapest TB test going. And I don't really think that it's going to get much cheaper than that, to be honest. Yeah. And so it's like, if the test is already as cheap as it possibly can be, and there's no kind of buying power available to implement it, like, even if you can detect 1.9 times as many people if you test 300, is that a good enough value proposition for these countries that need to test more? I'm not sure. I guess I'll have to wait for the cost effectiveness analysis.
Well, we are at time, so we better wrap up. As mentioned at the start, thank you once more, Emily, for taking the time to put this together and present today. And especially because you've just had a big move, and I know you've just come back from Cambodia doing very important work there. So I'm very grateful to have you and the excellent discussion that you had.
Great.
Thank Carrie for helping with the session today, and Nishita, who's always in the background doing all the hard yards. I wanted to mention once more, on the 5th of November, we've got Sarah Bernays and Du Trin Huang, who are presenting on mobile app technology and integration of patient care for TB patients around the world, specifically, I think, in Vietnam, but they will touch on other places, I believe, as well. And we may have a final session in December, so stay tuned for that. Look forward to seeing everyone again then.